Thank you very much. You probably realise, as well as a radiologist, I like pop music, and we mentioned a musician this morning. So I'm going to follow on to start the lecture. I was going to try and wake you up with this, but you don't need to be woken up because Jenny's talk was fantastic. But I'm going to talk about Ian Jury. Ian Jury had a group called the Blockheads, and that probably explains to you a little bit of his humour, which was on the edge, avant-garde, so if any words I say in a minute offend you, I'm sorry, it's Ian Jury's words, not mine. But he illustrates 4 points that are important to this conversation. One is he developed polio at the age of 7 in Britain's last polio epidemic. And that changed his life. He was a normal boy before that. He was an angry, fairly horrible man after that. Probably because of the schooling that he had in the School for Disabled. He got polio in a swimming pool in Southend-on-Sea. So the first point is the ambulance at the bottom of the cliff is damned expensive compared to prevention at the top of the cliff. The next year, polio vaccination was introduced into Britain, so he could have been saved. So that's point one. Point two is he died of colorectal cancer. And again, screening programs are what we need. Prostate cancer, same as colorectal cancer, because it's cheaper, more effective, and it's good medicine. The third point is he didn't like to be patronized. And I think Jenny's example is a perfect way of not patronizing people. Include them, bring them with you. Patronizing is soul-destroying, and sometimes medical profession patronize, so I apologize. So his point about not patronizing was he was asked to write a song for the Year of the Disabled. He wrote a song called Spasticus Autisticus. So I'm sorry if those words offend you, that's the name of the song, and he wanted it to be a protest against patronizing. Why should he write a song for the Year of the Disabled? Because he had polio. And the fourth point is there's a little phrase in there about prostate cancer research, and it goes, I dribble when I whittle because my middle is a riddle. Okay? So unfortunately, people with prostate cancer do dribble sometimes, and more so after surgery. And this is what we were talking about before, quality of life, and that is what a lot of the exhibitors there have, are devices to stop us being socially embarrassed by our dribbling. But the middle is a riddle is important. We need to solve that riddle. We need to solve prostate cancer. And this is where I'm going to try, in my own little way, to help in that enormous jigsaw, one little piece. And this is called F18 PSMA, which sounds, well, anyway, it's a bit over-scientific, but let me tell you what it is, because I think it's important, and hopefully we have, go on to the next slide. And this is what it is. It's a radiopharmaceutical, okay? And it's an important one for the diagnosis of prostate cancer. I talked to you this morning about MR. Well, this, I believe, is an advance on prostate MR. This is how we make it. I'm actually the chairman of a radiopharmaceutical company. I'm Big Pharma, I'm called. We're actually a very small pharma. We're down at Wellington Airport, but we make for the whole of New Zealand radioisotopes to keep the PET scanners running. So mainly FDG, but this is our latest product, which I'm very proud of, because New Zealand is a world leader. Okay, you saw a talk this morning with choline 11 mentioned. That's what they use in America, and it's streets behind this stuff. So we are really leading the world, with some help from our friends in America and in Australia. So we're down at the end of the airport, and why are we there? Because we want to supply the 6 PET scanners that are in New Zealand at the moment, and we can make bucket loads of F18 PSMA, whereas Mercy, and I take my hat off to Mercy, they're the first people who got PSMA scanning in New Zealand and Auckland, can only make 4 patient doses a day. So their volume is limited by the technology. Our ability to deliver to all scanners is much higher. We could deliver 10 doses to each of the 6 scanners. 60 doses a day could be delivered, or more, in fact, if need be. As I say, we're based at Wellington Airport. We're called Cyclotech New Zealand. And we're not generator-based, so that's the points to there. And it's also important to mention Hamilton here, because prior to that, we could only supply FDG into New Zealand without Hamilton, because the supply lines were too long even for a cyclotron-based machine. So because we're supplying from Melbourne, now we're supplying from Wellington. Hamilton's included in that mix, and do PSMA scanning. So why the need? Well, it's pretty self-evident in a group like this, but prostate cancer is common. It's the most common cancer in males, and it increases with age. And although a lot of men will die with prostate cancer, not of prostate cancer, it is the third most commonest cause of death. So it's important. And it's poorly staged by our current technology, which includes MR, as I was talking about this morning, CT, particularly hopeless, FDG PET, pretty hopeless. And you'll hear in medical conferences, staging is paramount. If you get the stage right of your disease, you can deliver the right treatment appropriate to that stage. So you'll hear that word coming up frequently. And how do we detect it? Well, PSA, the blood test, is a good source, and there's been a lot of controversy about whether men should be routinely blood tested for the PSA, and at what age, and I won't get involved in that, but only to say that I'm an advocate, because if you don't know you've got a disease, you can't treat the disease. And I think early treatment, or at least early knowledge and active surveillance is a treatment, is important. Then there's the digital examination, which your GP may or may not give you. It seems to be, medicine seems to be delivered these days more at a distance than up front and personal, like it used to be when I trained. I was pleased to say that I diagnosed a rectal cancer when I was a houseman in casualty with a patient who was obstreperous, came in drunk, but complained of rectal bleeding. So getting close with a finger is important still. Okay. However, incidental is the most common way it's diagnosed, and it's usually diagnosed late. And you were talking about the Maori incidence or prostate cancer, and it's usually diagnosed later for a variety of reasons. And to me, unfortunately, that's not acceptable. I'm an active interventionalist. I'm somebody who believes if you know what you've got, you can stage it, you can treat it. Here is what we call it. We call it the TNM system, and this is the staging: tumor, nodes, metastases. And in prostate cancer, the tumor is obviously in the prostate. The nodes are usually the local nodes of the pelvis and the paraortic regions in the upper abdomen, and the metastases are often in the bones. We stage it with, and Rod was telling you how to improve the guidance of the biopsy. So we call this the Gleason score. It's what the pathologists see down his microscope. But that detects what's in the prostate gland. It doesn't detect what's outside it, if there is anything outside it. So these are the nodes and the metastases, the N and the M of the staging. And we use a variety of other agents for that. Unfortunately, none were particularly good for early detection. There was one agent here which I'm sure none of you will have heard about if you're not in the medical profession, because it's rarely used in New Zealand, but was used in America and Australia in particular. It's called Prostate, and this is the clue to where PSMA scanning comes from. But first, let's go back a little bit. I'm ahead of myself now, talking about the test when we need to know what equipment we're going to use for it. And we're going to use two bits of equipment fused into one. So they're called PET-CT scanners now, and amazingly that's because they're a PET machine and a CT machine fused together. They're actually physically separate underneath the covers of the scanner. The CT is the first bit you go in, and the PET scan's the second bit. But they are two separate machines in one. And a lot of medicine is now developing hybrid scanning. You heard Rod mention that. Whether they're physically co-located or whether you merge one set of images with another with software, it's fusion scanning. And that's the inside of our, well, was until we actually replaced it just a few weeks ago. That's the inside of our scanner. So there's the CT scanner in the front, and there is the PET scanner at the back. And I took this picture through the console. So there, in fact, is our emergency kit superimposed upon it. But that was while that was being installed at the Wakefield site. And what do we use in CT scanning and PET scanning? Well, we use X-rays and gamma rays, and that's all part of the electromagnetic spectrum. And when people talk about radiation, they start to get a little bit frightened. It's a scary term. You can't feel it. You can't usually see it. The only bit you can see is the visible spectrum here in the middle. It's a tiny bit of the whole spectrum. But we're using bits down here. We're using very small, very controlled amounts of radiation, and so that it's safe to use. And there's a whole load of regulatory frameworks around the world to make sure that doctors only use safe amounts of radiation. In New Zealand, this is now called the Office of Radiation Safety. It's part of the Department of Health. So we're a highly controlled industry. And very basic principles is we pass X-rays through the body, and if you divide the body up into the grids like this, any attenuation, that's any blockage of the beam as it goes through your body, is detected and mapped out. So it's a map of how much your body can block the X-rays. And of course, bones block more X-rays than the fresh air in your lungs does, so that gives you the differential between the two. And then we apply the PET bit of it. And we do that slightly differently. We give you an injection of a radioactive isotope, whether it's the PSMA or sodium fluoride for bone scanning itself, or FDG, which is the workhorse oncology agent. And that has these scary antimatter bits in it. They're called positrons. And they are antimatter, and they move through your body. Well, they actually move inside one cell. They're very short track. And they slow down as they interact with tissue. And when they get down to this amazing value of 105 keVs, that's an energy level, they meet an electron and they both turn it into energy. So antimatter and matter both fuse and just form energy. So it's that Einstein equation. And they're very special particles, as I say. They're always 511, and they always come out opposite sides of the cell, so they're 180 degrees apart. And if you measure where they hit on this detector ring around, you can work out where in the body they came from. So you can measure down to very small amounts of size, so you can be very accurate in your pictures. And then we fuse them together. And sometimes people get a bit confused with fusion scanning because it's like, well, that's a lot of information in one picture. The way to think of it is like the weather map. There we have the outline of Australia. Here we have New Zealand, and we are on the map, okay? And there's a great controversy at the moment about where's New Zealand gone to. We've been disappearing off maps. Well, we're here still. We're just at the edge of the world, and if it's a flat Earth, we might fall off soon, but don't worry. So this is a fused image of the weather map, and this is a fused image of the CT scan and the PET scan. The PET scan, in this case, is showing a lung cancer at the top of the lung there. And then, because with imaging, if it wasn't complex, you wouldn't need doctors. So, and I like to keep my job. I'm sorry. So I can tell you that they aren't cancer. That's a kidney. That's the spare material. So there's an interpretation that goes into the image. So we are useful after all. And then we're going to get back now. Now we've learned about how the technology works, how we use it for PSMA scanning. And well, there's an old agent called Prostate. It's been around for about 20, 25 years. But it had a problem in, this is the PSMA molecule as it sits in your cell membrane. That's the cancer cell membrane. Everything has antigens or usually attached to the membrane. But the bit that they could tag on with Prostate was this bit which was inside the cell. Well, you imagine that bits outside the cell have difficulty meeting bits inside the cell because there's a membrane plastic bag around it to keep the two separate. So Prostate only worked on dead cells when the cell membrane is disrupted. So the signal was very weak. And it also used, I think I've put it in here, indium, which is a very poor radioisotope for medical imaging because it gives you a very fuzzy picture with very little anatomical resolution. So if you could see it coming from the prostate, you were being lucky when those old scans. So it fell out of use when the new trendy CTs and MRs came along. But we've resurrected it because not only is there this what's called the internal epitome of the antigen, which is here, there's lots of extracellular bits. In fact, it's like the Sky Tower in Auckland. It goes up much more than it goes down into the ground there. And there's bits up here we can tag on to. And the other thing about PSMA, which is rather odd in a way, it's called prostate specific membrane antigen. That's what PSMA stands for. Well, it not only comes from the prostate, it comes from a lot of organs in the body, and one of the brightest ones are the lacrimal glands, the bits above our eyes that make tears. Heaven knows why, but that's the body for you, which is always a wonderful mystery, which we try and solve some of the problems. So it's not only prostate, but other bits, so we have to subtract those from the image. It's not, the S stands for specific, it's not specific. It does not come from your normal prostate. The signal for PSMA scanning in a normal prostate is Zilch. Okay, only comes from prostate cancer, so it should be PCSMA, but people who named this didn't put the C in it. Okay, it does belong on the membrane, and it is an antigen. And prostate cancer has 100 to 1,000-fold increase expression of this antigen. This gives us a beautiful tag we can mark prostate cancer cells with, so we can work out where the prostate cancer is separate to where the normal prostate is. So it's quite a useful tool. And this is the group of antibodies that attach to the antigen that makes it work. They're called the J591 antibodies. So that's a little bit of naming, but lots of medicines full of acronyms like that. And the first group was this Pompers group in Johns Hopkins, made this substance, which is what is used in Mercy Radiology in Auckland. It's gallium-based imaging. And it's a beautiful agent. The only problem is you can't make very much of it at once because the generator doesn't generate very much of it. So the search was on, and there's another one in that group of compounds called DCFPYL, and it really just relates to the amino acids that's part of this antigen group. And you can attach F18 fluorine to that group quite easily. And this is where the fluorinated PSMA imaging comes from. And it looks pretty similar. And this is the fluorinated one. And as I said before, they're the lacrimal glands. There are salivary glands. There's a larynx. That produces it as well. It's actively uptaken in the kidneys, excreted in the urine, and is present in the bladder. And this is the gallium version over here. And there are slight differences. And that's important in terms of what I'll tell you on the last slide. So if you keep awake for the last slide, you'll get my take-home message. And the message is hope, by the way. There's a little bit more background here. And again, there's always subtle differences between different medicines. But one of the most important things to measure here, to look at here, is we piddle when we dribble, and a lot of men have trouble with incontinence, so we have to be very careful in the scanner we don't lose any spare isotope around the scanning, because otherwise it destroys the whole image. So these are all very practical points I'm mentioning. But then it comes forward to some key questions. Do we want to know we've got prostate cancer if we're not going to die of it? Can it be diagnosed after we're dead? And there's two things here. This is what I'm talking over-diagnosis bias, and you'll be very aware of biostatisticians worry about these things an awful lot. So if you're not going to die of it, but die of other causes, knowing you've got prostate cancer is not important. If we diagnose it early, but you still die of other causes, is that important? So that's called over-diagnosis bias, and it's very important in the healthcare question because we've got limited financial resources for healthcare in New Zealand and in any country of the world. The other one is called lead time bias. Does it help to know you've got prostate cancer earlier if it does not affect the time of death? Okay, you would think the earlier you diagnose it, the better you could treat it and possibly cure it. And I'm an optimist, I believe in that, but that needs to be statistically proved. Otherwise, we're wasting a lot of money. And so I'll leave that to others and the research that comes out of it. I can provide the tools that will help with an early diagnosis, but the question is, does that alter healthcare management? And then this is the reason for all those questions is the cost of diagnosis. The health budget is enormous. Can it be better directed? Can primary healthcare prevention, vaccination I mentioned earlier on, can we direct? Is it better value for money to direct your healthcare there than into late treatment, the ambulance at the bottom versus the fence at the top. So these are very important questions, and I have no answers to them, but they're up there for discussion. I'm a radiologist. We tend to be at the bottom of the cliff, I'm afraid, but I do understand the need for providing the fence at the top of the cliff. In terms of time, I'll skip over that, but basically what it means is we used to measure nodes by size. So the improving technology means we can now measure by disease, which can be smaller than before. So we can detect lymph node metastases with PSMA scanning when they're 3 millimeters, whereas before with CT or MR, we were relying on a 10 millimeter sized node. Again, is that important? Does that help the clinicians direct their treatment better? And here's some analysis of the New Zealand cases of fluorinated PSMA. I presented these at Rome, and again, we're well ahead of the Europeans and the Americans in the number of PSMA cases we have put through. We're world leaders in this in New Zealand, and we should be very proud of that. So these in blue are the people we didn't detect at that PSA, and that's less than 0.5. And the orangey color here is the ones we did detect. So we're detecting in all cases, there's 196 patients in this cohort when I analyzed the data. We could detect 5 patients with a PSA of less than 0.5, okay? Now, the standard level of PSA testing is 5. So we're now detecting below what the standard standard indications are. So again, a whole range more questions open up. It's a Pandora's box. And as you can see here, we actually failed to detect more than we detected when it was 0.5. But between 0.5 and 2, we did better than not detecting it. And as we got up to the 5, the old threshold, we nearly 100% detectability of the cancer that was producing it. And then if you look at those figures, for those who've had their prostate removed, the primary has been removed, so any PSA value is abnormal. These were called biochemical relapses in the past because we couldn't find out where they came from. Now we can find where they're coming from. So that is, again, 0.5. Of those, again, we failed to detect more than we detected, but we detected 5. That was the bell. I shall be quick. We detected 5 really down these very low levels. So we're getting very good at detecting metastases in this case, not in prostate recurrences because there's no prostate, but those who had brachytherapy or radiotherapy will be detected in the prostate gland itself. So here's a few images and some details here. We perform it 90 minutes after we inject the radioisotope. So the patient has to come and then rest while the isotope is going into their tissues. We give a CT, contrast-enhanced CT scan, so we need to know exactly where it all is, and separate it out from the spare isotope in the ureters. And this is my point earlier. There is no PSMA in a normal prostate. The bright colors here, the brighter the color on the scale at the side indicates more activity. So that is the prostate cancer in the prostate. Here is you can see the size we can get down to. This is 3 millimeters. So you can see, again, it's a very localized area within the prostate. We've got it's a relapse after radiotherapy and raised PSA. Here's another one, not quite so bright, but again, still quite clearly different from the rest of the gland. We'll skip that in terms of time, but basically it's showing we can separate the ureters from the metastases. And again, there is the ureter, and here is the metastasis. This is a lymph node metastasis, not to bone, but to lymph nodes. And here is the overall map. And here is another patient. These are brachytherapy beads, for those of you who haven't seen them. These are little radioisotopic beads that will kill the cancer in situ. And again, here's unfortunately is one that's not been killed. There's a little blue showing a local recurrence. And these are often at the bladder base, where we try and spare the bladder base so to reduce the incidence of incontinence. And of course, the recurrences aren't only in the prostate, but can be elsewhere. So here's another one with a lymph node mass. I think, yes, here we are. Small lymph node at the side of the pelvis. And there is the CT of that, and it's very hard to see. It's that little dot there. So we would miss that in a normal CT scan. Here is one where the recurrence is in the seminal vesicle, extending back out from the prostate. Here is one in a rib. So this is an osseous metastasis, a bone metastasis. And again, you can see these are over here. And the patient also has some lymph node metastases in the back here. And we used to pick these up with a bone scan, and here is a bone scan picture of the same one. The problem with the bone scan is it didn't pick up the soft tissue metastases, and here it is. There's the lymph node, but of course doesn't show on the bone scan. So the PSMA scan gives you bone as well as soft tissue. And here's a case that goes against all medical training. This is a lung metastasis. Now, lung metastases are meant not to happen in prostate cancer, but I can tell you that that was taken out, and it was oligometastectomy, the removal of low-volume metastatic disease, is important, as we discussed earlier, and I think will become a very important point of medical care in the future. How does it compare with the MR, which is our current gold standard? And the answer is pretty well, actually. We were concordant. There were 39 cases that had an MR and a PSMA scan. There's a good correlation. They were concordant in 29, so it showed where in the prostate gland the tumor was, and 29 of those 38 were exactly the same. If they were discordant, the MR was positive and the PET was negative in 4, and not statistically different, but there was 5 where the PET was positive and the MR was negative. So these can be, you can use both to get an increased resolution of your clinical problem. So in conclusion, therefore, PSMA imaging is highly sensitive. It's got good lesion detection down to 5 millimeters, we quote, but I say I have seen lesions as small as 3 millimeters. We can detect lesions now in patients with PSA in the low digits. It's available throughout New Zealand. There are now PET scanners, 2 in Wellington, 1 in Hamilton, 1 in Wellington, and 1 in Christchurch. So there's good geographic coverage. And most importantly is it will improve staging, and with staging, therefore, will intuitively improve treatment. Its current use in America, which is, they don't do a lot of PSMA scanning, but they do have indications for it, is in castrate-resistant relapse when the PSA has risen. But as I say, from that work we've done here in Wellington and other studies in Germany is another country that uses quite a lot of PSMA scanning, there's probably a role of PSMA scanning right at the front end of prostate cancer detection in the primary gland as well as in the metastases. And this is the bit I was mentioning here with a bit of hope. There's a field of medicine called theranostics. It's a made-up word. It's a mixture of therapy and diagnostics, okay? And there's just been the world's 3rd Federation Theranostics Conference in Melbourne a few weeks ago, where these agents were discussed. The first example, by the way, of theranostics is the treatment of thyroid cancer with radioiodine. It works. There's an agent here called lutetium. It's one of those rare earth metals. You probably have it in your phone. All these rare earth metals make phones work. But anyway, this one, lutetium-177, is a beta emitter, and it will kill tumors, cells in close confinement to the source, closer than brachytherapy will do. It's an injectable material. And it tags to the same ligand as the F18 does. So with the fluorinated PSMA, you can build up a dosimetry plan for your radiotherapist to administer this. There's been some provisional trials in Australia, and it's very exciting. It's very low morbidity and good suppression of tumor activity. So that's an interesting development that's come out of the PSMA work. And I think at that point, I might say thank you for listening, and I hope I haven't put too many of you to sleep after lunch.